Jamie, I think we're live. You ready to begin?
Fantastic. Hi, everybody. Welcome back. I hope you all had a good, restful holiday. In some cases, I'm sure in others might have gotten some rest and maybe it wasn't as great, but we're grateful to have you back, and we're excited to kick off this year with this director speaker series. And we're so excited to have Dr. Salas here for this conversation. I also wanted to put on everybody's calendar as we're getting back into the swing of things to keep this on your radar. Upcoming director speaker series, January 27th, we'll hear from Dr. Joya Creer-Perry. February 22nd, we'll be hearing from John A. Powell. Those went out in the email with their information, as well as the link to past speaker series. So for those of you who wanted to hear more and couldn't attend or want to go back and re-listen, we welcome you to do that. It's now posted on our website. And with that, just to let you know that this will be recorded. And if you have questions after David and Dr. Salas have a conversation, if you have questions, you'll put it in the chat and I'll help facilitate that conversation at the end. So with that, David, I'll turn it over to you, and thanks so much.
Well, thank you, Jamie, and thank you to the team at CCC and to Karen Migdale and to you for helping us continue this series. And welcome, Dr. Salas. It is a pleasure to have you. To the team at AHRQ, I want to remind you that this is our second conversation about environmental and climate change. And we had an opportunity in the fall to speak with our colleague, Dr. Jody Sherman, about how the healthcare system itself contributes to climate change and issues around greenhouse gas emissions and decarbonization. Today, we're moving to the second part of the HHS strategy for the healthcare system, and we're going to talk about how healthcare delivery and the care we deliver in the healthcare system needs to respond to climate change, and how the system itself can become more resilient. At the end, we'll talk about also a third speaker series, which we hope to have, that's going to focus specifically on the issue of environmental justice. And those are the three components that you've all heard us talk about that are part of HHS's strategy for the healthcare system. With that, now happy to introduce you all to Dr. Renee Salas. I'm going to read the biography, so please excuse me looking down, but there's a lot to say. Dr. Salas is a practicing emergency medicine physician in the Department of Emergency Medicine at the Mass General Hospital and at the Harvard Medical School. She is also an affiliated faculty member at the Harvard Global Health Institute and a Yerby Fellow at the Center for Climate Health and Global Environment at the T.H. Chang School of Public Health. She received her medical degree from the Cleveland Clinic Lerner College of Medicine, during which time she also received a Master of Science in Clinical Research from Case Western. Her Master's of Public Health is from the Harvard T.H. Chan School of Public Health with a concentration in environmental health. She has been the lead author of the Lancet Countdown on Health and Climate Change, U.S., since 2018. I believe the latest version of that, 21, came out in November. And she's also served on the original planning committee for the National Academy of Medicine's Grand Challenge on Health and Climate Change, where she continues to serve on committees related to this work. Dr. Salas engages in research on how climate change is impacting the healthcare system and works to develop evidence-based adaptation models. In 2021, she was elected as a new member of NAM. Congratulations on that, and welcome. Let's test your mic.
Let me unmute there. Yes, thank you so much for having me. It's an honor to be here, and Happy New Year, everyone.
It's great to start the new year with you. Thank you. So I'm going to start the conversation, and for the team at AHRQ to remember, I have a few questions. We're going to spend probably 20, 25 minutes setting the stage, and then we're going to turn this over to you all. The goal of these sessions is really to help all of us at AHRQ meet with people who are at the cutting edge, moving our thinking forward about healthcare delivery in the US to improve our work and our impact. So you've got a tall order, Dr. Salas, but I'll start by saying, as an emergency room physician, how did you first become interested in the intersection of climate change and healthcare?
So I was actually a first year practicing attending physician in 2013 and heard a lecture about climate change and health. So every lecture that you do actually does have impact. I'm proof of that. And they referenced the first Lancet Commission on climate change and health. And I dove into that head first. And I very clearly saw how it was already impacting my practice within emergency medicine, especially internationally, because I was working abroad more so at that time in my career, but then began to see it even here in Boston. And so I saw that it was going to increasingly make it harder for me to achieve the very tenets that I committed to when I went into medicine, which is to prevent harm, improve health, accelerate equity, and all of this within a landscape of optimal healthcare delivery, which is optimizing access, cost, and quality, which you guys all know very well.
So what was it that you saw in Boston as an example of how climate change was already affecting your practice?
So in medicine, we are very diagnosis driven. I mean, especially in the emergency department, I focus in on a primary diagnosis, and I may identify other secondary diagnoses, but given the pace and our goals there within the emergency department, the primary is what I focus on. So I'll give an example. There was a young girl who came in with an asthma exacerbation, and it was her third one that week. So I remember vividly sitting down and talking with the mother who was just beside herself because she was doing everything the doctors were telling her. And there are words that will always resonate in my ear. And she said, what am I missing? And I think I asked myself that question of what are we missing? We were providing optimal care as I looked through her records. And that really began for me, this process of really looking upstream. And, I feel like in the emergency department, I'm pulling patients out one at a time, only to see many more behind them. But it's only when we walk upstream and that we can see what's causing patients to fall into the river in the first place. And when I walked upstream, I saw that the burning of fossil fuels was contributing to air pollution, which was inequitably harming my patient in particular, but also leading to and driving climate change, which was, in this case, and evidence has subsequently confirmed this, that actually pollen seasons are 50% longer because of climate change, directly attributable to. And that really was driving her difficulty because we were experiencing record pollen levels at that time. So as I saw that and then actually made that diagnosis, I very quickly recognized, though, that the toolbox was very different to address climate change as a secondary diagnosis, which inevitably secondary diagnoses are just things that make it harder for us to either treat or prevent, manage a primary diagnosis.
That's an amazing story. I love how the connection of the individual patient opens us up to seeing the bigger picture. I've often run out of time with people and they didn't get everything they want to say done in these talks. So I'm going to flip the script a little bit and ask you, before we dive deep into lots of issues and some of which you've already raised, if you want, I'm going to give you this chance to tell the AHRQ team 1, 2, 3 top line messages that you hope they will walk away with from our discussion day. Can you hit the high notes?
Yeah. The impacts that climate scientists have been warning us about are here and now, and that is increasingly going to be our future. And so I hope that we can all sort of walk away and have a discussion that recognizes that climate change, at least the way I think about it, is a meta problem, meaning it underlies so many of the other problems we see, but is also a threat multiplier, meaning that it makes existing problems worse. And the reality of that then is that it touches everything. So I would argue whatever it is that you're working on, I promise you it touches that in some way, whether it's quality, safety, equity, value. And it may be small to start and indirect and maybe insidious, but it's there. So that's sort of the first piece. The second one is recognizing that because of that, we have to add a climate lens to healthcare delivery. So I would challenge you to add a climate lens to everything that you do, which I know we'll talk about here in a bit. And because the reality is we can't look in a rearview mirror anymore to understand what's ahead of us. And we need evidence in order to guide our path forward. And then the third piece is just optimism, the fact that we are in a period of time where there is urgency to act, but we can still change the course. And that is why this conversation is so important.
Love it. Okay, let's dive in then. And I'm going to start with the middle one because you opened me up there and said, so let's talk more about what do you think it means to apply a climate lens to the work in quality, safety, equity, and value that AHRQ does?
So unfortunately, I can pull from the headlines for an example just to help frame this. at least in the way that I think about it, and look forward to learning from all of you as well. And that's the Pacific Northwest heat wave, which happened in June of 2021. So unfortunately, not very long ago. And that heat wave has been deemed by climate scientists to have been impossible without climate change. And that's rare for that to happen, but I think it's a really profound example. So heat-related ED visits were found to be 70 times higher during that time period than they were in 2019. And there were over an estimated 600 premature deaths in 1 week, just in certain regions. And 4 hospitals in Washington state lost power. And as many of you know, backup generators often don't cool down facilities. ORs had to close because they couldn't actually guarantee that they could create safe temperature and humidity. So I bring that up as a really, headline grabbing example of heat and extreme weather, because I think we know climate change is making heat waves hotter, more frequent, lasting longer. Hurricanes are actually stronger, wetter, and slower because of climate change. And wildfires, the seasons are lasting longer and burning more acres. So those are headline grabbing things that really point to this reality that we are seeing these overlapping hazards, and that these compound hazards can lead to cascading failures. And as Catherine Hayhoe really outlines, and she's a colleague of mine, but she says that climate change is loading the dice. Yes, we had all of these events before, but now we're loading the dice that they're going to be more intense. So with that as an example of why we need to then add a climate lens to everything that we do, in reality, I'm a photographer, so that's probably why I gravitate towards the lens concept. So any photographers out there, you get that. It's a thing that you put on your camera, and then when you look at everything, you're seeing it through that lens. And in my definition, it's understanding how climate change is impacting things now, and then how is that going to increasingly change in the future.
So the challenge is for us thinking about how to help healthcare systems, improve quality or safety or equity. We need to include in that, how is climate change part of safety, and how will it become more driver of safety in the future? And you gave us the example there that, if I'm understanding correctly, that the ORs shut down, couldn't do surgery safely because they couldn't guarantee temperature control. And so that speaks to the making the facilities more climate change ready. But you also talked about the patients and premature deaths due to heat waves. And we've got to have healthcare delivery systems that save more of those people and need to be thinking about the future. Is that in the weather space am I close?
Sorry, yes. And I didn't want to jump sort of too far ahead. I know we have certain topics we're looking to target, but the idea is that I would argue that everything in regards to thinking about different aspects of quality and safety, as we think about these disruptions, for example, how is that impacting safety and quality? How are we able then, as and I think just talk personally for myself as a clinician, able to still provide that safe, high quality care in environments where I have disruptions to the very infrastructure and supplies needed? And another example is that intravenous saline actually was on shortage. And that was something I was dealing with here and even in Boston. And if you actually connect all the dots back, we see that over 50% of saline is produced in Puerto Rico. And Hurricane Maria, which was shown to be intensified because of climate change, actually disrupted facilities there, which led to these cascading failures. So that caused me to hand patients literally cans of Gatorade if they didn't meet certain criteria for which to apply or be able to give them intravenous saline. And if that's water in a bag, then think about, again, all of the other sort of ramifications. So there's so much that we need to understand in this space. And so these are sort of some of the more, I think, tangible ones. But I would argue we could, anything that people bring up, I would love to sort of do a thought process of thinking through how climate change could be impacting that. Because I would argue I can, knock on wood, I've always been able to find some way to connect it.
That's a great challenge. So for the team at AHRQ, start thinking about problems that you see, bring it on, and we'll get back to that. So supply chain interruptions, you've talked about, heat events, increased pollen counts, People have talked with us in the past about vector-borne illnesses, COVID, not necessarily being vector-borne, but in communicable disease changes. Are there other areas, just quickly, that climate change, we should be watching for how climate change is going to hit them on health?
So I sort of think about it, there's a few buckets, and I'll just sort of map them out, and happy to dive into those further. So I think that what we've talked about so far really encompasses at least my mental framework around disruptions of healthcare delivery, infrastructure, power outages, supply chains, and again, what the downstream implications are that for the very, tenets and foundations of what are priorities for you. Thinking about utilization. So we know that climate change is exacerbating existing disease, and that's especially true for exacerbating inequities, and is also creating new disease burdens and new inequities. Thinking about migration and displacement of populations, and how climate change can drive the long-term piece of migration, but also the temporary displacement following some of these climate intensified events. And what does that mean for healthcare delivery? And then also thinking about sort of this disruption and utilization combination, and what does that mean actually for providers, and what skill sets do clinicians need that may be outside of their typical toolbox? If I think about the toolbox framework, and sort of that just-in-time education that's needed for them to cope with the challenges ahead. And then sort of that last bucket, which is, probably in some degree a culmination potentially of different factors, but is the costs, how is that impacting healthcare costs, and how does that vary at different levels while we're thinking about payers or insurance systems or even healthcare systems themselves?
Oh, that is a brilliant strategy for AHRQ, a framework for AHRQ. Thank you. You hit on all the parts. So let's take it to us and think about AHRQ. So as we've talked about, AHRQ's goal, our mission, is to improve healthcare systems and their ability to deliver safe, equitable, high value, high quality care, to produce tools and resources that help systems use evidence, apply evidence, do the right thing, make the easy thing to do. And then our third core capacity is in data and analytics, and helping people understand how healthcare is and is not working. So from your perspective, both as a researcher, as somebody who's been thinking about, and you've laid out for us the effects of climate change, given how big this possibility is, where do you think are the high impact areas that you'd like to see AHRQ work in, either health system research and evidence development, tool development, helping health systems think differently, or data and analytics, either for the country or for the health systems themselves? Anything start spinning. What do you want to see us do?
Well, how much time do you have? No, I'm kidding, but I'll keep it brief. But I think I'll start out with just a framing that we're thinking about these very same things, and I'll just share the way we're thinking about it, because I don't want to be too prescriptive, and sort of want to just take a step back and tell us and really share our approach. And that's really thinking about a theory of change and understanding what change do we ultimately want to see, and trying to identify what are those actionable levers that are highest priority that will have the quickest impact. I think it was, the amazing RFI that you guys put forth with environmental justice and equity and these issues. You had something in there about what evidence do healthcare systems and policymakers need to make decisions. And I don't have the answers to all of that and exactly what the highest priority are, but I, undoubtedly would sort of turn that question and say, if what are those levers and where can the most immediate impact occur? And I'll secondarily just, share and say that there's confidentially been working with the New England Journal of Medicine Catalyst, and there's going to be a report coming out in March that really shows that there's an enormous opportunity here, based off of some survey work that, data and guidance is needed and the motivation is there. And so I think there is enormous opportunities, and I think you guys are enormously well positioned to make those connections. So, and then I'll, try to get more granular and stay away from my theory of change call here. But, as we think about utilization and cost, obviously those two things are somewhat tied together, because you have to understand what the potentially attributable or increased utilization is, in order to understand what the true increased cost is. And so I sort of think about it as a pie. I don't know if I'm hungry, but if I think of the pie being how all of the different ways in which climate change is impacting health and disrupting healthcare delivery, that's sort of the big picture. And we've seen slices of the pie, heat and there's emerging evidence around extreme weather. But honestly, this area has been starved for research support. And so there is so much that we need to know. And being able to start to understand the utilization and sort of cost implications, I think, can help make that case potentially for people to act and see that it is actually cost effective to begin acting on climate change now, both from a mitigation standpoint, in order to minimize the threats that we will see and the human suffering and disruptions that we will have, in addition to beginning to increase adaptation and resiliency. So if that is an optimal target, then I think that's a key one. And then even again, just from that general tools and recognizing that there is an enormous appetite and desire with this awakening healthcare population to begin engaging in this and being able to start to provide really tangible tools based off the knowledge we have is another, low-hanging fruit.
It's so much fun to be speaking with somebody who already talks like they're at AHRQ. All the things you were just saying, I think resonate really well with our team. And I'll highlight that I'm going to ask our colleagues in CFACT, especially, one of our centers that focuses on those issues of cost and utilization, some of these questions about can we develop better evidence, or how would we get the field to start generating that evidence about the relationship of climate change to cost and utilization and the factors as a potential motivator, one of those levers for creating change. I can hear another part of our team saying, wait a minute, evidence doesn't drive change. We need those tools to make it easy. And you said, do both of them. So, okay, we're there with you. So much more I want to do, but looking at the time, I want to move on. The first of the 3 points you brought up was this idea that we need to, as we're thinking about climate change or using a climate change lens for all of our work, is understanding climate change as a force multiplier. I want to give you a chance to dive into that a little bit more. And I know I've heard pieces of it, but what else do you want to teach us about that framing?
I think the one thing I'll add, and I'll try to keep it brief so we can try to cover more ground as well, and again, always happy to dive more into things, is recognizing that we are actively watching our health system undergo a stress test with the COVID-19 pandemic. I worked over the New Year's holiday and so just came off a stretch of clinical shifts, and we had to shut down certain parts of our emergency department because we did not have sufficient staff, nurses and medical assistants, because everyone has Omicron. So of course, given the hazard of what I focus on is that I'm thinking, well, if a climate intensified disaster keeps part of our emergency department from being unable to access the hospital, yet we have record volumes, we are starting to work through some of these protocols in regards to how, where our vulnerabilities are and how we can try to become more resilient. So I think about it in that, and I bring that up because if we think about climate change as a threat multiplier, meaning that it takes these existing vulnerabilities that we're seeing with other things and obviously making those worse. And so there was some work I was a part of that looked to see, as we try to minimize the COVID-19 pandemic, how is climate change acting as a threat multiplier on that, as we try to keep people in their homes and quarantining or isolating during a heat wave if they don't have access to cooling, and driving people to cooling shelters in order to try to protect themselves from heat-related illness. So that to me is, again, thinking about this as interconnected, and we think we can't separate all of these things, because whether we're trying to prepare our healthcare system or understand these vulnerabilities for the next pandemic or for the next climate-related disaster, they're all interconnected. And if we incorporate these lenses and get the right perspectives around the table, we can become resilient and tackle numerous problems at once.
So that's an important word, resilience. What are some of the things that you've been seeing, given all the places you've been, of exemplars or places we could look to see how people are building more resilient delivery systems? whether that's ERs or hospitals or primary care? What have anything to share?
Well, obviously, you know your local institutions best. And I think, I'll share one thing that I know MGH, and I practice at Massachusetts General Hospital, and they have done assessments to understand how climate change exposure pathways, whether that be wind or flooding or sort of other hazards, what those are now, and then understanding with different climate models, what those will be in the future. And I know that in others like, Kaiser Permanente, who's been really leaders around sustainability. And I think there's been healthcare systems that have really advanced with sustainability. And that's wonderful. You had Jody come and really talk about that, right? Because it's all a vicious cycle. How is climate change, or how is healthcare contributing to climate change? And then how is climate change then further exacerbating healthcare delivery and exacerbating health inequities, right? We have to stop the vicious cycle. But we also now need to start to think about sustainability and resiliency as an interconnected pair, right? Any resiliency we integrate should also be sustainable to not be contributing to that very problem. And I think there's been leaders in sustainability and healthcare in the US, and we're now sort of in that burgeoning infancy of really trying to integrate true resiliency into the system. And that means obviously understanding that climate lens, what the impacts are now and what they will be in the future, in order to operationalize this. And then the last thing I'll say is and I look forward to, I was thinking about this actually in preparation for this talk. And so I'm vetting it here with you guys, but, thinking about disaster protocols. And I think this probably comes from us doing unprecedented protocols just this weekend. And that I had a clinician say to me, well, if we're on capacity disaster all the time, when does that just become our reality? And so can disaster protocols, we used to think about them as rare events, but if these stressors, and especially climate related stressors, are going to happen more frequently, how do we incorporate that into our daily existence so we can have the resiliency and surge capacity to handle whatever it is that's coming at our systems?
Huge challenge there. I think we've been watching the healthcare system work at surge capacity, and we know that if you run an engine at its peak capacity for too long, it breaks down. And so that challenge of, if this is the new normal, how do we retune so people aren't burning out and systems aren't burning out? That is a billion-dollar question, at least, that we need to answer. And that it touches, I think, a little bit on well-being. Glad you're able to be with us today, and that your teams are making it through the crush that we're experiencing. But maybe it brings in for AHRQ that as we're bringing the climate change lens and the resiliency lens, that's also a time to not only bring in our equity lens, which is where I'm about to go, but our clinician well-being and the health. If the people providing care aren't themselves being cared for, the system's going to break down again. So the human resiliency factor. And before we get to that, though, I was going to bring you. Sorry, I'm going to reach over here. This is something you actually wrote. You said early evidence shows that climate change adaptation and mitigation actions can sometimes exacerbate inequalities. And I found that fascinating. So you've been bringing up the importance of us thinking, and we're going to continue that work on how climate change has not been equitably distributed. But what you've raised here is that there's emerging evidence that our work to fix and to address may actually exacerbate. Could you tell us more about that so we don't walk blindly into that?
We guide everything that we do. And I think that health and equity can not only be a motivation for why we act on climate change, but can actually guide our response. But I have been told, as we've gone on this journey and worked with colleagues and seen data emerge, that we really need data for us to understand the implications of interventions that we think will be helpful or help us adapt to climate change, or even help mitigate climate change and reduce greenhouse gases. So I'll pick one example from each. And so thinking about mitigation, for example, there's some work from some colleagues of mine that looked at electric vehicles. And if you were to increase the charging stations at different parts around the country, yes, we might be using less fossil fuel generation for our cars, but if the energy from this is still coming from fossil fuel generated power plants, then that actually is going to increase air pollution in certain areas. And that inevitably is going to inequitably harm certain communities, even as we try to further mitigation. And then secondly is thinking about around the adaptation front is, you can look at statistics, and we really broke this down in the 2021 US brief, thinking about that, over 90% of households have access to air conditioning. So you may think that that is great. That means that we're well on our way, but what does access mean? And actually, as you start to look at that, and probably of no surprise, that there are certain populations that access does not actually translate to health protective cooling. And so how do we actually understand and look at that data to identify what the right metric is to understand if we're appropriately protecting households from heat-related illness? And statistics may seem as if we are successfully heading in the right direction. And the other counterintuitive to air conditioning is the fact that it also, again, is generally pulling from fossil fuel generated power plants, which is increasing air pollution, which is thus harming the very community that you're providing protections to.
I hope our team who's working on the social determinants of health just heard that really within that very interesting and helpful broader description, that idea about, are we hitting the right metrics, and should we be looking at access to health protecting cooling as opposed to just an air conditioner? That's a great thing for us to remember. So as we move forward, what do you, and given how many people you've spoken to around the country and around the world, what do you think are some of the leading factors? So I'm getting now to that question of where are the levers that are preventing healthcare systems, healthcare leaders, CEOs, C-suite people from taking action in the climate space? Any guesses?
I think it's my hypothesis, and I think there's emerging evidence as well around this, but first and foremost is the why. I think that people have not seen the connections. And again, the way that climate change has been creating new disease and exacerbating existing, and creating new inequities and exacerbating existing inequities, and disrupting healthcare delivery has, arguably been somewhat insidious and maybe indirect or not as clearly seen. But unfortunately, as climate change accelerates, we're seeing it more and more in the headlines. And unfortunately, we can pull more and more examples. So I think people are beginning to make that connection. But I think the first one has to be why, and helping them see that that climate action is a prescription for improved health, improved healthcare delivery, and accelerating equity. And then I think the second piece is, even as there's been this growing recognition, there has still been a lack of clear guidance on exactly what to do. And I think we are beginning to be in this space where we have a increasingly activated healthcare sector. And many people just don't really know what to do. I can't tell you how many emails I get just asking, I'm here, what can I do? And so we're at a really unique opportunity here in order to provide clear guidance on steps and to unify and really coordinate and have unprecedented collaboration around this. And then the last piece is resources. I think institutions and healthcare systems that have enormous resources, and I'm blessed I work in one, they have to make that connection and see that investing upfront in these types of issues is actually cost saving. So the CEO or president of Boston Medical Center, we had an event right before the pandemic happened. And when we asked her, why did you really step forth and work on sustainability? And she said, money. She said, it helped my bottom line. It was the shortest answer ever, but it was the best one because it tied to what every CEO cares about. But so they have resources, and those who have it need to know that it's cost effective to do this. But then for the ones who don't have resources, if we think about our small healthcare systems, especially in rural areas, that we desperately need to remain in existence in order to provide care to those individuals, they may not have the resources. And so thinking about how we can ensure that we can also provide the capital and resources needed to do what needs to be done, because even if they know we need to do it and they have guidance on how to do it, they may not actually be able to execute effectively.
All good points, really helpful. So I'm going to get to the third area you brought up, which is the sense of optimism that you feel. And I think you started giving us some of that at the same time you're taking it away. So it's a nice balance here. But what are some of your thoughts on where that, if you could let us in on what's going to come out in March? What's giving you optimism about this?
Yeah, so I view the healthcare sector as a sleeping giant. There have been, different, to continue that metaphor, or the analogy, right? There's the hands maybe have been moving and the feet are starting to twitch. And that's been happening where there have been different areas and sectors around healthcare, both in the US and globally, that have, seen this and been working on it. But we, again, need to have a unified, coordinated, and unprecedented effort to attack this, because clearly attacking climate change how we normally tackle problems is not sufficient because of the urgency. And as you probably know much better than I, as far as, the delay in actually changing practice and system change and the uptake of recommendations. So we need to think about this in a whole new way, and transformative, which is exciting. And so I honestly believe that, and this is what drives me and gets me up every morning, is that if we can awaken the sleeping giant of healthcare in the US especially, that will have global ramifications and can catalyze the global conversation in ways, right or wrong, but in ways that I think nothing else could. And after spending 2 weeks at the COP26 at the UN Climate Conference, I am more convinced of that than ever. And so what we do, or, unfortunately, what we don't do, has global ripple effects. And so as we awaken, I'm excited about a forthcoming effort that is really trying to really foster this unprecedented coordination and collaboration. I mean, we are stronger together. And as an emergency medicine doctor, I consult. I'm sort of the jack of all trades, but I also very quickly know when I need to consult. And so there is a need to get multiple people around the table with a multidisciplinary perspective, and to be able to really have government and academia and NGOs and public health sector to work together in ways that we have never before. So that is obviously just sort of a teaser of what's to come, and obviously really look forward to continue conversations. But I just wanted, really as a plea to all of you and to give optimism, is that I think all of us in the health sector have an enormous opportunity to make these connections and really provide the evidence to guide our path forward. But I would argue that all of you have an even more unique opportunity and arguably responsibility to do that, because you guys can move the needle arguably in ways faster than other agencies or sectors could.
Well, that's exciting to hear somebody say the government can move quickly, but we'll take you up on that. I think AHRQ does do that. I do have a few more questions, but I would love to turn it over, Jamie, and ask folks and the team for questions as well. So Jamie, have we gotten any, or you're on mute?
Yep. Sorry about that. Yep, we have 2 questions so far, and so I'll start off with. Do you have a framework for considering desirable actions at different levels of the healthcare system, e.g., individual, unit, or practice organization, state and national? And what are the most impactful examples of individual actions?
Great question. And so I think this is, as I sort of talked about this forthcoming effort, I mean, what we are really seeking to do is circling back to our earlier part of our conversation about these levers of action. And I think we know that there is and thankfully, and I believe this, that there's going to be hopefully an accelerating exponential increase in the foundation of infrastructure within the government and beyond, that works on climate change and health. But given the urgency of the issue, we need to begin having really targeted high impact actions now. And so we want to try to think about what those different levers are. And I love the fact, the way you break that up in the sense of individual and, again, within your sort of healthcare unit and beyond. And I think that there's a traditional way of breaking it down in regards to thinking about adaptation. And so I'll just share how I sort of think about it, right? Is you got to make it personal for people. And so an effort that is actually sort of blending into this forthcoming effort was the Climate Crisis and Clinical Practice Initiative, in order to help show clinicians across the board, not just physicians, but how climate change is impacting their day-to-day clinical practice. Now that makes it personal, and you can begin to have sort of targeted ways that they can incorporate it into their clinical practice, whether it's adding screening questions, or amending the way that they think about prescribing certain medications that may increase the risk for heat-related disease. But then that's the downstream. And then if you sort of run all the way upstream, right, and begin to connect them to that, burning of fossil fuels, then you can begin to sort of move that backwards and see how healthcare systems are disrupted, and different implications there. And then really try to make that tie that climate action is a prescription for improved health and equity, and that suddenly makes greenhouse gases more real when you think about how it's impacting pollen levels or disrupting healthcare delivery. So I think trying to frame it in a way that allows it to become personal first and bring them into the issue and make them see it, and then sort of how they can begin to have impacts at different levels. And then as far as, the actual levers themselves, I don't know what the answer is. And that's something that we would love to kind of continue the conversation as we think through what those might be, and inevitably learn from the wisdom and experience that you guys have. And then, sorry, I have the question up here. So I'm in regards to sort of most impactful individual actions. I think that first and foremost is just talking about it. And if we think about the three key populations that I think health care sector sits at the center of, it's the general population, which is our patients. It's decision makers, for which we can advocate. And obviously you have, and your institution or agency has, access to certain levers that others don't. And then there's sectors outside of health, and we can make health and equity as a central driver and motivator in a way that others can't, and can make climate change personal, but then also help it guide the response as we've been talking through.
Great. I think this next one, we talked a lot about, systems and how to get at things in the healthcare system, but we haven't talked a lot about is kind of patient-centeredness. And so this question gets at, how can we move the climate lens upstream from hospital and ED to primary care to make individual and communities more resilient in the face of change? And what are the best intervention points in the clinical care spectrum for patients' climate-related risks to be addressed?
Great. Yeah, so I think, I'm sorry, I'm sort of talking through all these are great. And again, of course, my mind's racing as I think about all the different underlying factors and how to sort of approach these questions. So look forward to continuing the conversation. But briefly, I think first and foremost, what that first question gets to is the need, and we've seen this with the pandemic, that any attempt to draw barriers between the medical community, the traditional medical community, and public health is artificial and detrimental. Our fates are unified together. And I think that is a key driver for this forthcoming effort. And I think a growing recognition across the board that we have to work optimally together. And so we have to think about how we can help protect our communities and sort of add that climate lens, so to speak, to all public health interventions, because again, these interconnected challenges are just that, interconnected, which means interconnected solutions, and being able to address multiple problems at once if we can just slightly tweak and take these different factors into account. So we need to prevent, pathology from occurring in the first place. The goal, right, is to be able to have it where heat is not leading to heat-related disease that is causing individuals to come to my emergency department. And so being able, that requires communication and coordination. And honestly, data is critical. I can't, even working with the Boston Public Health Commission, there are aspects where they would love to have data around certain issues and aren't aware of, literature that maybe has been published. And so being able to really streamline that connection and build those bridges so that data can be easily available. So for example, someone in Nebraska can look and say, okay, well, here's the communities that are most impacted with heat-related disease and as measured by ED visits and hospitalizations and mortality. And so how can we then use that data in order to target our limited resources? And then the last piece, the second part of the question around intervention points. So this is something that we are thinking about and is sort of born out of this climate crisis and clinical practice initiative. And again, we would love to coordinate and collaborate on this because we are stronger together and would love to continue discussions. But thinking about clinical practice guidelines within specialties, so the ways that people could add a climate lens to their daily practice. And so thinking about climate-related risks. And so that way, again, we have to make this easy for clinicians. There's so many demands on their time that if it is not something that can be easily incorporated into a patient visit, it's not going to happen. And I think that there's also a recognition that, well, should clinicians be talking about climate change? But the reality is that we have a mandate, and this is my belief as a clinician, to optimize their health. And so whether we talk about elevated pollen levels and tie that all the way back to climate change, or we just discuss the fact that these things are happening, either way, we need to protect that patient and provide them with the knowledge, education, and interventions in order to optimally protect their health and the health of their loved ones.
Great. So there's one more, and I want to take this one. This is from one of our NAC members. So thank you to I know we have a bunch of them on the line right now listening, and so that's kind of like our advisory council to AHRQ and gives us strategic advice from important stakeholders. And so thank you so much for joining us. So this one comes from climate change has various effects on human health, including indirect effects on infectious diseases. What can we do to decrease these risks of infections like the current coronavirus pandemic?
So I think again, thinking about the concept of meta problem and threat multiplier, there are ways obviously in which climate change is perhaps directly and or sort of indirectly impacting diseases. I think vector-borne diseases are those that have been best studied or best connected to climate change, whether that is thinking about Lyme disease, malaria, dengue, obviously internationally. And so I think we need to understand what those impacts are first and foremost. But then we also have to, as again, and you get asked about the coronavirus. And so I guess bring a little bit of pause there because I think it also leads to sort of a broader concept around planetary health. And I sort of view climate change as a gateway drug. I'm sure you didn't expect to hear that today on this call, but as we think about how the environment impacts what we do, then I think you can begin to think about it even in a broader way. And it can sort of lead to that understanding that deforestation and increased connections with wildlife and loss of habitat, obviously all of that has implications for disease transmission. And so I think that first and foremost is a very complicated relationship to understand and something that needs a lot more work because we can't optimally prepare for what we don't fully understand. And we need to start to see where some of those vulnerabilities are in order to then even identify potential interventions. And then, the last piece I'll say is just that I view sort of our current understanding of climate change as an iceberg, recognize the irony of that framing, but what we see right now, I fear is just the tip of the iceberg. I think that the largest mass of these interconnections are underneath. So for example, there's some early work that showed that rising temperatures is linked with microbial resistance to antibiotics. Now that as a clinician for me is enormously concerning as we think about that threat multiplier implications, that we think about that, if I give an antibiotic to someone with sepsis and they don't respond, and if climate change is making that worse, and that's a frightening reality. And so again, these are the things that we need to understand to optimally prepare for.
So thank you. You just brought another one of our teams who is combating antibiotic resistance into the thing. So a great tie-in to another one of our centers and our work. Before, Jamie, we look at the others, I have a few final questions, Renee, that I'd love to put to you. And I let you know these in advance, but I think we ask them to everybody. Before we sign off, is there anything you had hoped to talk about with us that we haven't touched on?
I think just to really stress that this is an unprecedented issue, and these things that we are talking through, obviously I'm just sharing my experience and some of the ways I'm thinking about this, but we're really at the infancy of tackling this problem. And that is, there's enormous opportunity for all of you to contribute. And I also, really make the plea that there is a lot of reason to have hope and optimism, because I think this can not only help to protect our patients and accelerate equity today by adding a climate lens, but it will make us more resilient for all challenges that we will face within healthcare in the decades to come. And this is the moment for action, and health can truly drive this conversation in a way that I honestly believe nothing else can. And so what we do will have enormous implications for the path ahead.
Well, thank you for that. Who else would you recommend AHRQ listen to, learn from, or partner with?
So the national, as I'm sure many of you may know, the National Academy of Medicine has developed a grand challenge. And right now their first task is really targeting the Action Collaborative to decarbonize healthcare, which I know that you have already had a session with Jody on the sustainability aspect, but it's obviously much broader than that. And then I also think just recognizing that this field is in its infancy. And so really there's a lot of people who do work that I think is really important to add a climate lens to. And so thinking about the researchers and the experts who are in an area that's really important for us to think about, that all we need to do is sort of add that climate lens to what they do and slightly tailor it to then be able to really start to get at the heart of these issues. And as I think about the urgency and wanting to rapidly build up our evidence base in order to develop, evidence-based tools that can really help move the path forward, being able to add a climate lens to existing infrastructure is a really quick way for us to do that, which again, why this conversation is very exciting. And then just the last point is recognizing that this forthcoming effort, it really seeks to not duplicate anything that already exists. Again, recognizing the urgency we have here. And so look forward to continue conversations around that.
Well, I think that, or I can assure you that AHRQ will be part of the HHS response and be at that table with you. So I look forward to that. I think I just saw a question come in, Jamie, that touched on evidence. So maybe we should
and
my final one.
Exactly. And it's building on actually what Dr. Salas was just saying. And so, are there key gaps in clinical evidence to protect health during climate events? And for example, you mentioned heat and prescribing patterns, but if there are others that you can let us know so we can help think about prioritization of our own work.
Yeah. So the way so there are not any standardized clinical practice guidelines that add a climate lens systematically or comprehensively. So, I think that, again, the short answer is there's a huge gap. And I think the way, at least, that we've been approaching it and look forward to feedback or in thinking about it is that because the US has such geographic variability in regards to how climate exposure pathways are impacting health and healthcare system disruption, is that what practice implications there are in Washington, for example, may be very different from Florida. And so understanding what these different practice implications are for different regions, I think is also really important. And then obviously recognizing that it's also the specialty based of, again, bringing it home to that clinician in regards to what they see in their day in and day out, and understanding how different aspects of their clinical care is impacted. And you can take that by exposure pathway. So heat is one, but you can also think about air quality implications, whether that be pollen or wildfire smoke. Obviously, a lot of the interventions may be the same. And so how do we start to think about interventions that can target multiple exposure pathways? If we think about vector-borne diseases and thinking about not only prevention in order to educate patients on, but also trying to educate clinicians for emerging vector-borne diseases that may be coming into their region that they have not historically seen. So sort of that need for education and, that sort of just-in-time education too. If there's emerging threats, how can we monitor those and ensure that those guidelines are being implemented and being able to connect that public health and medical community. So again, really thinking about it, the exposure pathways, which vary geographically, thinking about it from a specialty-based perspective and moving through all of those exposure pathways for each specialty. And then obviously having variation also within local practice environments, which can then be tailored by a local institution.
Amazing. So I'm going to ask a final one. So the team at AHRQ loves to learn, which is one of the reasons I love working here. So I always ask folks, are there resources that you'd recommend? Websites, articles, compendiums, conferences, where people who are interested in learning more about one or more of the topics that you'd recommend?
So as far as, we've talked a lot about data and metrics. And so currently the global Lancet Countdown, this is obviously on the global landscape, but as far as just general ways that things have been tracked to date around this, there's the global Lancet Countdown, which is an annual report published across 5 working groups. And some of them obviously have more direct relevance to things than others, as far as within AHRQ's purview. And then the New England Journal of Medicine also really has a growing sort of climate crisis and health topic page, which has a collection of different articles and resources there. And then Health Affairs actually put out a climate issue for anyone who isn't familiar with that in December, which had sort of a suite of different articles, which hopefully would be stimulating to think through. And obviously one I led was around adding a climate lens, again, that theme of my work, to domestic healthcare policy. And a lot of it is just meant to be as a thought exercise, so to speak, around how different things could be integrated, how a climate lens could be integrated into different things.
I'm sort of shocked that my colleagues didn't challenge you to do that game of taking a topic and doing it, but we'll do that another time. I want to thank you so much for the time you spent with us, for those ideas. I want to thank the team who's been listening, and encourage them, all of us at AHRQ, to keep these conversations going. Because Renee, I think one of the things I'm taking away is that on the individual level, talking about this is part of what's going to keep it at the front and allow us to adopt the lens and move that forward. So let's keep the conversation going. Jamie, any other housekeeping updates that you wanted to?
Already made our announcements about upcoming. Again, if you want to check out our website about, some of it came up in some of this discussion. So if you want to check out Dr. Sherman's talk and go back to learn more and kind of connect the dots there, please do that. And any other questions, please let us know. And if you have ideas or things that you really want to hear about that we haven't addressed that you think other AHRQ staff might want to know, we're always happy to take ideas from other folks.
With that, I'll invite the team at AHRQ to say our thanks and applause in the chat as we wrap up this fantastic talk. Thank you so much, Dr. Salas, Renee.
Thank you for having me.
Welcome back to AHRQ anytime.